and welcome to today's EBAC accredited webinar from the ISCP's A to Z of CV Pharmacotherapy series. And today's program will be focusing on Inclisiran and a jab going a long way. My name is Doreen Tan, and I'm an associate professor with the National University of Singapore Department of Pharmacy, and I'll be moderating the webinar today. I'm joined by Dr. Kritin Banditangkol. He's a pharmacist from the Chulalongkorn University, Thailand, and he will join me in moderating as well. Kritin, over to you.
Hi, everyone. Okay, so it is with pleasure that we are joined today by a fantastic faculty, Professor Krzysztof Filipiak, Rector of the Medical University of Marie Curie in Warsaw, Poland. Hi, Dr. Filipiak. Okay, then we have Professor Bernard Van Jung Chung, Professor in Cardiovascular Therapeutics and Head of the Division of Cardiology at the University of Hong Kong. Hi, Professor Chung.
Hello.
And we have Dr. Alberto Lorenzati, who heads up the lipid clinic and cardiovascular prevention in the Hospital Córdoba, Argentina. Hi, Dr. Lorenzati.
Hi.
Thank you, everyone. So we're very privileged to have a nice panel of speakers, very experienced, and I'm sure we're all going to be enjoying ourselves learning a lot about Inclisiran this evening. Today's broadcast is brought to you by the International Society of Cardiovascular Pharmacotherapy, or ISCP, and of course in collaboration with the Radcliffe Cardiology team. This is going to be a very interactive session with two real-world cases that we'll discuss, and we'll toggle that with questions and answers. So if you look at the little box at the bottom of your screen, please feel free to submit your questions to the faculty via the question module on the webpage. And we'll endeavor to answer as many of them as possible towards the end of the broadcast. So before we begin today's session, let's have a quick look at our learning objectives for this evening. Okay, the learning objectives for this evening is also on the website, and we should be able to go through that learning objectives also on the website. All right, so I'd like to hand you over to Professor Filipiak, who is going to be presenting to you all about Inclisiran. So let us put our hands together to welcome Chris.
Hello, everybody, once again. A warm greeting from early afternoon Warsaw in Poland. And it's my great pleasure to give a short introduction on Inclisiran, the drug that is the hero of our today meeting. I will start with a potential conflict of interest. And my first point that I would like to touch is the times that we are living in. I would say that we are living in a new era of pharmacotherapy. I mean, the drugs based on RNA or mRNA technology, and Inclisiran is one of them. Why I'm saying that we are living in such an era? Because, well, from pharmacological point of view, you could say that we have at least 4 classes of different pharmacotherapy on different drugs which are based on RNA. I mean, the most probably popular now are, of course, mRNA products. I mean, billions of them have been given as Moderna and Pfizer-BioNTech anti-COVID vaccinations. So in fact, I would say not millions, but billions of people all over the world are treated with this kind of mRNA products. There's another class that we will not deal today, RNA aptamers. They are very short fragments of RNA, and we have one, in fact, drug registered nowadays in ophthalmology since 2004. And there are 2 classes of drugs that are important for lipidology and will be important for lipidology. We are saying that there are SERNs or serans. Serans, the name comes from this short interfering RNA, and this is the hero of our today talk, I mean Inclisiran, but there are also products which are based on antisense oligonucleotide RNA, and we are saying sense because all of the international names of those drugs have the ending sen. So you probably remember that the first sen was eteplirsen, registered in Duchenne dystrophy, then was golodirsen, vitolarsen, and nusinersen. So a lot of drugs that change the history of spinal muscular atrophy treatment. This is a proof that we have a lot of new discoveries in pharmacotherapy in RNA technology. So let's come to serums, because we will be talking today about Inclisiran. So what for are serums made? And there is I would say, an era of serums, and a lot of serums are coming for different indications, because you probably have seen from the very first film animation just before we started our meeting that the idea is quite simple, that you just act on mRNA, and mRNA can be mRNA for different proteins, for different genes, and therefore you could think about a lot of different diseases not connected with each other, in which serums will be very important drugs. Nowadays, there are some serums tested in ophthalmology, there's one serum tested in nephrology, there are some serums tested in hematology, in dermatology, there are a lot of serums tested in oncology, and also there's a lot of serums tested which are the serums, which act on liver, and one of them is Inclisiran, because you have seen that this mRNA that is touched by Inclisiran is an mRNA which must be delivered to the hepatocyte. So Inclisiran is one of those 22, or maybe now it's about 30 different serums tested in this kind of diseases. Well, from historical point of view, of course, not cardiovascular pharmacotherapy was the first one that was the part in which serums were registered. You remember probably that the first serum ever registered by FDA was patisiran. So this was the first serum that was registered, and it was registered in amyloidosis patients, and there are some other serums for this indications also now available. As for serums, now FDA has registered 3 of them: patisiran, givosiran, lumasiran. Inclisiran was registered firstly in Europe by European Medical Agency, but a lot of other serums are waiting in a queue to be registered in USA and in European Union and all over the world. When you look at those different serums, you can see that some of them are really so-called breakthrough therapy. So the therapy for the indications that has never been addressed from a pharmacological point of view before. And these are such indications like hyperoxaluria, for example, some kind of amyloidosis or acute hepatic porphyrias. All these states can be addressed with serums. And of course, the hero of our talk is Inclisiran, which was registered in hypercholesterolemia. I said that a lot of experts, and I agree with those experts, are saying that serums and SERS will be most important drugs in the future lipidology. And to prove this statement, I will come to the Inclisiran. Inclisiran, you remember that it's let's call a third step, a third stage of treatment in hypercholesterolemia. After statin ezetimibe, we have Inclisiran, but we also have some monoclonal antibodies which are also being used and registered for PCSK9 modulation. In fact, Inclisiran is the newest technology. And of course, Inclisiran is not the only attitude, pharmacological attitude to lipidology, because RSENs are also being registered or will be registered in a moment. And I will just remind you that, for example, we are very advanced with clinical trials with pelacarsen, so RSEN, not Ciran. So now Inclisiran is registered in lipidology, but maybe in a few years, pelacarsen will be registered, which will be very important in lipidology in reducing lipoprotein A. I put it on one slide because, in fact, if you think about serums or RSENs, the technology is very similar, but one is based on so-called small interfering RNA, and second technology is based on antisense oligonucleotide. But in fact, the outcome of this technology is the same, that you block mRNA, so you, in fact, you block the protein that is based on this specific mRNA. Those serums are also very important in lipidology, in tomorrow lipidology, not only RSENs, as far as you consider, for example, a reduction of lipoprotein treatment. And I must remind you about recently published Apollo trial from American College of Cardiology this year, in which one of the serums, it doesn't have a name, it's SLN 360, but it's very similar to olpasiran, another serum which is being evaluated in lowering lipoprotein A, and you probably know that these are very effective serums because they can produce even 80% reduction in lipoprotein A. Well, I would put a thesis that, all these RNA technology drugs will be the future of lipidology, and we maybe even in the future will get off all the old drugs, which for me are, for example, monoclonal antibodies like evolocumab or alirocumab. That's something that illustrates how quickly this pharmacotherapy progress is really taking place, because I'm talking about old drugs which are in fact not very old. I mean, evolocumab and alirocumab are also very sufficient and very effective and very new drugs. But I do believe that they are really we get rid of them, and new drugs on RNA technology will be more popular. I mean, serums like Inclisiran. Why I'm saying about this? Because when you look at the other fields of lipidology, for example, we have new drugs which affect ANGPTL3, and these are quite important drugs to lower, for example, triglycerides. And you probably know that we have a very new drug registered in USA, evinacumab. And nowadays we have some data that probably better one and more cost-effective even will be vupanorsen. So as you see, RSEN and serums will replace, in my opinion, all drugs, I mean monoclonal antibodies. Now, coming back to Inclisiran, what is evidence-based medicine for using Inclisiran, and how we do in practice. How we do in practice, we will see in clinical cases that we discussed today. But first of all, the mechanism of action. I think I don't have to go into details after this beautiful animation film, which we have seen just before the starting. You remember that it's a small interfering RNA. So in fact, this Inclisiran, after coming into hepatocyte, will incorporate into RNA-induced silencing complex. And the result will be that this specific mRNA for PCSK9 will be cleaved, and there will be inhibition of PCSK9 synthesis, and a very long acting inhibition, because it's acting half a year. So almost 6 months effect after such a single dose of this drug. Of course, we have now new guidelines. I'm from Poland, so I must follow European Society of Cardiology guidelines. These are the guidelines that we follow in Europe. And the newest version of this European guidelines, 2021, is, of course, introducing Inclisiran into clinical practice. And you can read from these guidelines that Inclisiran will reduce LDL cholesterol, something about 50–55%. Well, how it comes that we know that it's reducing LDL cholesterol by 50 or 55%? When you look at the data, it's really like that. I mean that the mean reduction rate is 50–55%. But I would like to draw your attention to the efficacy from different trials at day 180, so after 6 months. And you can see that there are even some patients in which we reported a reduction of LDL cholesterol of 80%, not 50. So 50 is a mean value, but there are some even individual patients in which Inclisiran can reduce LDL cholesterol after single jab of 80%, and this effect is half a year. I must say that this mean effect, 50% reduction, is of course effect which is much stronger than statin effect. You have such a comparison on my slide here. And what's more important, it can be seen also in monotherapy. So it's very important that even in patients which are totally statin intolerant, you can imagine that you can give only Inclisiran and reduce LDL cholesterol above 50%, which means that for a patient with very high risk, cardiovascular risk, you can think even about monotherapy of Inclisiran in the future. Now, what we know about clinical trials, you have such a slide here. We have a lot of clinical trials with Inclisiran. This is a series of clinical trials with the acronym ORION. And we know from those ORION trials that has been ended that a drug is really very efficient, that there are no evidence for different side effects, what is very important, and so the safety of the drug is also very good. I know that some experts are saying that we still lack ORION trials with hard endpoints. So the proof that Inclisiran will prolong life, will reduce myocardial infarction, will reduce stroke. But as we know, as the drug lower LDL cholesterol to this extent, we can make such exploration. But on the other hand, we have some other trials that will be ending in next year or 2 years or 3 years. And those trials have a lot of patients and have also so-called hard endpoints. I tried to calculate all these trials, and those trials which are coming soon are the trials that involved over 70,000 patients, and those trials are being conducted in over 50 countries. And these are typical trials in secondary prevention, also in primary prevention. So we will have definite answer that this drug will lower, I do believe, all the traditional endpoints like in a big statin, for example, trials. So what is my prediction for the future of this Inclisiran and on this use in clinical practice? Sorry for the slide. Let's treat it as a little lesson in Polish language, because I didn't have time to translate it from Polish, but I do believe that you understand the slide. It's saying that, for example, if you look from the patient point of view, and if you are using statins, you need to at least to swallow 365 tablets a year. If you have PCSK9 monoclonal antibody like alirocumab or evolucumab, you at least need 26 jabs a year. And now we are here, we have Inclisiran, and in fact, you can treat patients with 2 jabs a year. So if here you have adherence, it means that adherence is the answer. I don't know if we can have something better. Maybe something better will be a vaccination once alive for anti-atherosclerotic vaccination or anti-PCSK vaccination, but now it's only a dream of the future. So as for now, I would state that Inclisiran has the highest adherence rate among all drugs used in hypercholesterolemia. And that would be my introduction. Thank you for your attention.
Thank you so much, Chris. We'll now go over to a time where we'll discuss 2 real-world questions. Just a reminder to the audience, please post your questions to the bottom of the page, and then we will collate everything and discuss together with the panel later on. Maybe I'll just pass the time over to Kritin for him to take the first case, and let's see what our experts think about the first case.
Okay. So the first case, so you could see that Mr. SS, 26 years old, admitted for acute coronary syndrome. So he reported acute dyspnea and chest pain with radiated to the jaw 1 hour before the EMS brought him to emergency department. His past medical history included single vessel disease about 5 years ago, treated with the dilating stent to the mid left circumflex, diabetes, hypertension, and dyslipidemia. So his medication right now is aspirin, 25 mg daily, clopidogrel, carfentanil, 12.5 BID, and enalapril 10 mg BID, atorvastatin 40 mg plus acetamide, metformin 1000 mg BID, glipizide 5 mg daily, and omeprazole 20 mg daily. So because in Thailand, we have like a national drug list and universal coverage. So the government will pay for some medication. So in Thailand, the aspirin dose we use modestly about 25 to 100 mg per day, and SGLT2 inhibitors or the GLP-1 receptor RA is not included in our national drug list right now. So our patients, most of the time they will get metformin and sulfonylurea. Okay. At ER and CAT lab, the ECG show new SCD press at lead V1 to V4. The troponin is positive. Angiogram show 90% occlusion at mid LAD, so it's the new occlusion. And the echo show regional wall motion abnormality with the EF about 52%. So if we look at to his LDL level, so on January, his LDL level fell 85 mg per deciliter. About 3 months later, it's rising. So on that time, the doctor prescribed acetamide for him on March. And then after that, his LDL level is declined. On June, it's declined to about 85 again, and other parameters quite not that bad. So his blood pressure about 130 over 25. His A1C is about 7.4%. HDL is about 42. Non-HDL level is 128. So this admission about September. before his schedule to see his cardiology. You could see that his LDL is still about 80, but still above the target based on the ESC guideline, should less than 55. So his LDL is still above the target that we would like to bring it down. Okay. So, okay, from the first case, I think the question, we will move to the Q&A question. So Doreen, please.
Thank you, Kritin. So maybe let's ask Alberto first. Alberto, what do you think about this particular gentleman here? Would you have added on Inclisiran? Would you have added on a PCSK9 inhibitor, increased the statin? What would you have done with this man?
Thank you, Doreen. This is a typical secondary prevention patient that we usually see in the real world. The thing could be, we can think about his goals in terms of LDL may be less than 55 according to European guidelines, but also may be less than 40 because he has a recurrent event. In this particular case, I do not consider increased statins because in this patient, we do not achieve the goals. Probably the best option is use Inclisiran, or if it's not possible, PCSK9 inhibition with a monoclonal antibody, because in some publication, we have seen that more than 80% of the patients on statins achieve to a European goal with addition of PCSK9 intervention, maybe monoclonal antibody, but for the reasons that the speaker has shown to us, the adherence is really, really probably the best using Inclisiran. I definitely will add, if is my patient, Inclisiran in this patient.
Thank you, Alberto. Let's ask Bernard. Bernard, what do you think about this effects of Inclisiran since Alberto has decided? Do you know of whether Inclisiran has got pleiotropic effects like statins?
My goodness, that's a very difficult question. I think because it's quite new, but preclinical studies actually have shown that Inclisiran may have potential pleiotropic effects like statins, and you know they seem to be very favorable. I mean, things like reduced oxidative products, you know, better endothelial function, less platelet aggregation, and fewer expression of, let's say, inflammatory cytokines. So these are all very favorable effects if they, you know, if they do occur in our treated patients. I mean, that would be very good because, I mean, you know, if you have platelet aggregation, if you have oxidative stress, if you have endothelial dysfunction, if you have expression of inflammatory cytokines, then, you know, that creates the milieu, the environment for atherosclerosis to progress and for thrombotic events to occur. So, but then, of course, you know, this is, at the moment, this is very much, you know, basic science level. But it will be interesting to see if these potential pleiotropic effects, plus the amazing ability to lower LDL cholesterol, as well as, you know, Lp(a) and a little bit of triglyceride as well, whether this translates into reduction events. From Professor Filipiek's talk, Christoph had, you know, it was very hopeful that, you know, these will be these benefits will be borne out in the long-term trials that are ongoing. So
Thank you. Thank you, Bernard. My screen has suddenly gone blank and I can't see anyone else. So if you wanted to say something to me, please. Oh, okay. Now I can see people. Very good. Hi, everyone. See you again. Okay. So I think there were other questions regarding the wonderful role of Inclisiran. And maybe I should pose this question to say, Chris. Chris, I think there were questions about whether bempedoic acid, is this better than bempedoic acid? And also, how do we predict the response of Inclisiran for each patient? Is it going to be like every single person that it will work for? And would it be unnaturally interfering with proteins that could cause genetic mutations? You know, at the start of the COVID vaccination, everyone was like, oh, worried about the mRNA vaccine, right? How it could cause genetic mutations. Did you have comments about that? Oh, I'm afraid Chris might be frozen. All right, maybe we'll get Alberto to answer the question.
Yeah.
Is it better than bempedoic acid? And is it always predictable for every single person?
The bempedoic acid is a very interesting drug. The bempedoic acid reduces the production, the cholesterol synthesis upstream to the action of the statins. And particularly, it's very interesting because the action is focused at the hepatic level. We do not foresee muscle contraindication or muscle secondary effect using bempedoic, but it's like I would say weak drug in terms of LDL reduction. I mean 20% at the most, 15, 18% at the most in terms of LDL reduction. But it's very interesting to use in combination with ezetimibe or even with statins. But in both cases, we do not expect so much LDL reduction. It's a different drug. It's an interesting drug. The cardiovascular outcomes trial is just finishing. I suppose, as Dr. Philip Pack said to us, every intervention that reduces LDL probably reduce for sure, I think, MACE, but we have to wait several months up to have the clear outcomes result. But in summary, it's an interesting drug, it's an oral drug, this is a main difference, once a day, 180 milligrams, but it's quite different. It's less potent than any PCSK9 intervention. I mean, monoclonal antibodies or Inclisiran. It's different. We can combine, but we cannot expect a strong reduction in terms of LDL reduction.
Many thanks, Alberto.
I
nice to
think,
have you back, Professor Philippiak. We were posing you a question. Yes. Could you maybe
sorry,
take the question?
you haven't heard me. I suppose I had a short weak internet. Well, I do agree with all the facts that Alberto said, but I would say that the main problem with bempedoic acid is that it lacks clinical trials. They are just finishing, but nowadays they are lacking. And it's quite important because when you look at the mechanism of action of bempedoic acid, I would say that it's drug competing with statin. So rather, I would say that it can replace in some clinical scenario statin. And probably you will agree with this because when you look at the pharmaceutical companies, they are investing also in a combo and bempedoic acid with ezetimibe. So they are trying to say us that it's alternative to the combo statin ezetimibe. So I think that we must wait for clinical trials, and it will be very hard for bempedoic acid to compete with statins. I mean, the drugs that are so widely just evaluated in clinical trials. But it's really quite interesting thing, and it's like a history of pharmacology. If bempedoic acid was first, not statins, I would say that it will be better drugs than statins. But it's second, so it arrived later, and I think it will not be the miracle drug.
So in summary, we're still in favor of Inclisiran. 1 for Inclisiran, less for bempedoic acid. Yes. Yes, Alberto.
Also, there is a secondary effect in terms of, not always, but it's a possibility in terms of uric acid elevation with the chronic use of bempedoic acid. It's a little problematic drug, as Dr. Philippe said, is the main focus is statin intolerant patients.
Mm-hmm. Thank you, Alberto. We don't have bempedoic acid in Singapore, I don't think, so I'm not that familiar with it, but I think that's a good call because a lot of our patients with high cholesterols are likely to also have metabolic syndrome, and they're probably bad eating habits with gout and all that. So the elevation of the uric acid, I think, is an important observation to be making about the bempedoic acid. Talk to us, Bernard, about the ability of Inclisiran with respect to working for every single person. Do you think this is predictable for every single person? And what do you think about the comment that it could cause genetic mutation, just like the mRNA vaccines for COVID?
Oh, well, thank you very much, Doreen, for those questions. Well, does it work on everyone? Probably better than most drugs that we know about. Because it's very strange, because if you have an oral drug, once you dispense it, I know you're a very good cardiovascular pharmacist, you can persuade your patient to have near 100% compliance, but most patients in the real world may not take all you give them. So I think it's something that's injectable, and better still, injected at quite long intervals, you're going to get 100% or near 100% compliance. So I think on that count alone, Inclisiran has the advantage over traditional therapy. And in clinical trials also, the lipid lowering effect seems to be quite consistent. And well, it's based on silencing RNA technology, and that's actually very precise technology, unlike small molecules where you worry about off-target effects. So so it does appear that really it's the effect is very specific. Would it cause genetic mutation? I hope not. And as Professor Philippe mentioned just now, I mean, we worried about COVID, mRNA COVID vaccines, causing mutations and all sorts of, perhaps even cancer and such like. But we haven't observed it after, billions of doses. So it's too early. I mean, the long-term trials of Inclisiran are ongoing. Too early to say whether there are some, unsuspected long-term adverse effects. But the short or medium-term adverse effect profile is just very, very impressive because it's so specific. Now, compared to, we were talking about bempedoic acid just now. So, I mean, it may affect the uric acid level, it may affect your blood count, it may also have, other side effects as well, which again, in the sort of lipid-lowering world, well, statins are very exceptionally well tolerated. And then, there comes along bempedoic acid, where we have to worry about, adverse effects. And then on top of that, its LDL lowering effect is rather modest. So bempedoic acid is an interesting drug. It may have its own niche for statin intolerant patients, but it's not really for the majority of patients. Whereas something like Inclisiran seems to be suitable for, wide range of patients, perhaps those who are absolutely afraid of needles. So if you ask, them to come back for injections, they'll stay away from your clinic. Then perhaps, those patients can go on take oral drugs alone. But otherwise, I think in future, this is a very exciting development.
Thank you, Bernard. I think there were a few comments about whether we need to worry about myocarditis. That doesn't seem to be a concern, according to the report so far. There was also questions about how you think you monitor this patient. So I think we talked about Mr. SS earlier, and I think Alberto had elected to add on Inclisiran for Mr. SS. I just wanted to pose a question to Professor Filipiak. Do you think that it will make sense at all to combine Inclisiran together with a PCSK9 inhibitor? From the way that it worked, I mean, the financial considerations aside.
No, as I understand your question, first of all, you cannot mix Inclisiran with PCSK9 inhibitors. Yeah, this is the same group of drugs, the same mechanism of action, or very similar. So, in fact, you must go into one or other. I do believe that Inclisiran is better because it has better adherence, it's more selective, and also you are discussing some potential adverse reaction. And in fact, from pharmacological point of view, always monoclonal antibodies have the potential of causing some kind of immunological reaction. And you don't have it with serums. So in fact, I would say that all these drugs based on RNA technology will in fact replace monoclonal antibodies. That's what I was saying in my introduction. But there's a second reason for such a thesis. And you know what's the reason? The reason is that when you talk to pharmaceutical company experts, they are saying that in fact serums and sersens are cheaper in production than monoclonal antibodies. We don't see it now when the new drugs are coming to the market because the prices are usually the same as class drug, I mean PCSK9 inhibitors, but I do believe that in fact the cost of production of serums and SERMs are really cheaper than monoclonal antibodies.
Thank you. Does anyone think there's a need to even monitor for the therapy at all? I mean, aside from the fact that someone is compliant to Inclisiran, it sounds so safe that there doesn't seem to be a need to give the patient a close TCU to watch them. Bernard?
Yeah, I agree. I mean, officially, there's no need to monitor anything other than the lipid profile or the cholesterol level to ensure compliance or you're not over-treating the patient. But I imagine in the real world, you will be monitoring these patients for other reasons, such as if they are already on a statin, then you might want to do some, let's say, maybe liver function or muscle enzyme from time to time, if it's indicated. And if they're diabetic, you monitor the diabetes in the usual way. So in fact, going back to our patient, I mean, not only do we need to treat his cholesterol, we should also treat his hypertension as well as diabetes better. But that's another story altogether. If we have time, we may go back to that. But perhaps I think there's another case coming up. Is that right, Doreen?
That's right. You're spot on. So I think we were having quite a good time discussing about the profile of Inclisiran for the first case. I'll give the time back to Kritin for him to introduce the second case to us. And this is going to be a lady, I think.
Okay, so sorry. Okay, on the first case, we talk about the case who have like a secondary prevention, who have like a recurrent acute coronary syndrome. So the second case, maybe a little bit more complexity because we will talk about like a primary prevention for the high-risk patient. So Mrs. TD, 65 years old, she is seeing her cardiology. Okay, she reported about slight tiredness sometimes, especially during heavy exertion. Her past medical history included diabetes for 20 years, and she already developed nephropathy and peripheral neuropathy. hypertension, non-familial hypercholesterolemia, gout, and obesity. Her medication included aspirin low dose, losartan 50 mg daily, amlodipine 10 mg, hydrochlorothiazide 25 mg, atorvastatin 40 mg, metformin 1 gram BID, sitagliptin 50 mg daily, mecobalamin, gabapentin for her neuropathy, and allopurinol for her gout. Okay, so her LDL level, typically uncontrolled lady. So sometimes more than 100, sometimes below, just a little bit below 100. So the last visit on the May, her blood pressure is quite high, 150. Her blood sugar is uncontrolled. A1C is 20.8%. Fasting blood sugar is 150. Serum creatinine 1.8. So her eGFR is about 28. Okay, and her LDL is about 108. Okay, so this visit 3 months later, still high blood pressure, uncontrolled blood sugar, and right now her LDL level is about almost 100 milligrams per day sleep, and based on her SCVD risk about 20.5%. So this is the second case. So I will bring back the Q&A session to Doreen.
So let's talk about this lady over here. And I think that she is already on atorvastatin at 40 milligrams daily. So I think the main question we want to talk about is what is the suitable LDL goal for this patient? How many on this panel are going to say as low as possible? Hands up. Okay, so that question doesn't need to be answered anymore, right? Essentially, the other related question is this. If Inclisiran is so effective, why can't we just use it as the monotherapy and a first-line drug for all our patients rather than going on statins? Has there been good evidence with other combination agents like ezetimibe as well? Chris, what do you think?
Well, I think I would say, based on clinical trials, that I can imagine such a future that you will give to a patient like this woman Inclisiran in monotherapy. But according to guidelines, of course, we have to use statin in such patient, especially patient with a very high risk profile with 20 years of diabetes. And therefore, the next step for me in clinical practice would be adding to atorvastatin another drug, and this drug could be Inclisiran, because when I add ezetimibe to this lady, to this atorvastatin, I will not achieve LDL goal. She has, as we have seen, 100 milligrams LDL on atorvastatin 40 milligrams. So even if I add Inclisiran, she will have another 50% reduction. So she will have an LDL below 55, and this is the LDL that she should have. In fact, I think this second case doesn't differ from the first case as far as the LDL goal is concerned, because in this lady, even in primary prevention, with such very high risk diabetes, she should have LDL below 55 milligrams per milliliter. So in fact, I will go with statin plus Inclisiran.
Thank you, Chris. So maybe we can talk about the effect of Inclisiran on the other lipid subfractions like lipoprotein little a and maybe HDL. Does anyone have experience with that, Alberto?
I think the intervention in the PCSK9, I have experience with monoclonal antibodies in the reduction of cholesterol remnant in this kind of patients. I mean, for example, this patient is very interesting to see the non-HDL cholesterol in her because she's a diabetic patient. In this case also, I agree with Dr. Filipiak that the goal of LDL could be less than 55 and the goal of non-HDL could be less than 85 milligrams per deciliter, and the patient has nowadays 150 milligrams per deciliter in terms of non-HDL. I have calculated the cholesterol remnant and it's around 30. I think this kind of intervention could be positive in terms of reduction of other lipoproteins, mainly lipoproteins that contains cholesterol. In these patients, VLDL is enriched by cholesterol, and also, as everybody knows, LDL is enriched with triglyceride, and for this reason, this kind of patient used to have a high proportion of small and dense LDL. In summary, I think I agree with Dr. Filipiak. This is a patient that we will add Inclisiran to a statin, and I foresee an interesting effect on other lipoproteins like VLDL remnant and cholesterol remnant that is present in all atherogenic lipoproteins.
Thank you, Alberto. Bernard, what do you think about the efficacy of Inclisiran if we wanted to save money and instead of doing the 6-monthly injection, we do it once a year? What are your thoughts about that?
My goodness. Well, I mean, in the early trials, it was given more often than 6 months. I think I would stick to 2 injections a year. That's already much less frequent than, let's say, if the patient goes on PCSK9. But going back to the patient, I can't remember, Doreen, can you remind me whether the patient has been started on ezetimibe on top of the atorvastatin or not?
Nope, she's just on atorvastatin alone.
Yes, I think that again is might be a very cost-effective option if she's already taking a statin, then to add ezetimibe to it, and then add either PCSK9 or Inclisiran. PCSK9 has the about in real world about the same cost, but obviously more injections. But then it's got the slight advantage of more outcome trials. So I think it's a 50-50. I think in future, patients removing or doctors removing to use Inclisiran instead of PCSK9 inhibitors. But I think at the present moment, it's sort of neck to neck. What's the other question, Doreen?
I think it was about the stretching out of the regime.
Oh, right.
Yeah.
Right. I wonder what Alberto or Christoph feel about stretching out because of the high costs, injecting it less frequently. Chris
or Bernard or Alberto? I'm sorry.
Well, I think we must stick to the registration, and the registration is every 6 months. And even if you remember some clinical practice, we are saying that even after the first jab, you should give the second after 4 or 5 months. So after the second jab, you are giving every half a year, but the first jab is a little less efficient. In my clinical practice, I have few patients on Inclisiran, and the second jab was given after 5 months. So even the cost of treatment in the first year is a little higher than in the second and third year. So we must remember about it.
Thank you, Chris. Alberto?
I would like to point out the thing that, for example, if we have more than 20 or near 30 years of experience with a statin, what's the main problem in clinical practice with the statins? Muscle symptoms? Not. Secondary effect? Not. The main problem is adherence. In clinical practice is adherence. You prescribe after the coronary care unit, for example, 80 milligrams per day of atorvastatin, and 6 months later, the patient is on 20. I don't know why, but it's on 20 or on 40. But Inclisiran is an excellent opportunity for adherence. 2 shots a year, and it's true that Dr. Philippak pointed out regarding the first year, the first shot after the second would be 3 months later than the first one, or 5 months later. And anyway, but beside that, 2 shots in a year is a very, very interesting option in terms of adherence and effectiveness. Also, 50% of LDL reduction with this intervention in a year is really, really impressive in my point of view.
Yes, I agree. I think we have an interesting question here. The question is, do we have to examine PCSK9 variants before deciding to give Inclisiran to our patients? Anyone?
No, we don't need that. I mean, in clinical trials, we were not doing it also. And a drug is really very, very effective. So in fact, there's no need for such thing. Maybe I would consider it in a patient in which, for example, after giving Inclisiran, there were no answer, but I haven't come across such a patient.
Thank you, Chris. Kritin, what's it like in Thailand? In Singapore, I think a lot of our lay public is very worried about statins when they're told they need to start on the statins, right? And so they will have all sorts of reasons to say they don't want to start on the statin. They'll go on sorts of diet therapies, and they keep delaying starting on statins. What is your experience like in Thailand? Is that the same?
Yeah, I think it's quite the same, because when patient got like a heart attack, they got like atorvastatin 40 milligrams, but after their LDL quite controlled, so they may refer back to the primary care. And then at the primary care, some physicians start to reduce the dose of the statin. Or sometimes the internet. After patient got some news from the internet, oh, my muscle got pain.
Yes.
Okay, so I stopped the statin. So
Yes.
I think a big at the same problems.
I agree with you. So I think earlier Alberto mentioned about compliance. I was going to say that sometimes it's the doctors that cause a non-compliance too, because sometimes your patients complain a little bit, and then usually the resistance on the side of the doctors would be, okay, if you're not happy about it, let's cut the dose. And I feel like the tolerance to cut the dose or to switch or to stop is actually quite low for statins. And it's somehow because people complaining about muscle aches and pains and everything else. But we do admit that the use of Inclisiran is going to be a lot more convenient for patients, especially if you're worried about adherence. And because you can give 1 jab every 6 months, that would actually improve adherence a lot as well. Well, I think we're going to come to the end of our session soon. Maybe I'll go around the panel to ask everyone. I think there were questions about whether you think Inclisiran will become part of the bundle of post-ACS care and all that as well. So maybe we can hear your views. If you were a member of the Pharmacy and Therapeutics Committee and you had to vote on adding Inclisiran into your formulary, what would you say to adding Inclisiran to your formulary? Maybe you can go around the room. We'll ask Chris first. What do you think?
Well, I would vote for it, but I must say that in my country, for example, we have some problems with Inclisiran because we have some kind of reimbursement only on monoclonal antibodies, so for alirocumab and evolocumab, and not for Inclisiran. So in some patients, especially in familial hypercholesterolemia and in a very high risk patients after myocardial infarction, there's a special program of reimbursement of PCSK9 modulation, but without Inclisiran. But I hope that it will change in a year.
What about Bernard? What do you think?
Well, I mean, this is not a hypothetical question. This is a question that, you know, I was part of a committee we had to discuss, and our feelings were, I mean, I think the downside, there are 2 downsides to Inclisiran. One is it's the expense, and the second is the lack of long-term outcome data. However, when we're deliberating, we considered that, very often you'll be using it on top of statin and ezetimibe. So at least the patient, has some cost-effective evidence-based treatment, and only if they don't reach target would you use Inclisiran. So I think we thought it's true and decided that it's worthwhile to include in the formulary. Not obviously as a first-line drug for everyone yet, but in selected patients, high-risk patients, we felt that there was a need for this.
Thank you. What about Kritin? Would you have voted for Inclisiran in your formulary?
In Thailand, we could not reimbursement for both PCSK9 or Inclisiran. So if I have to choose one, based on our patient habit, I will be vote for the Inclisiran because I know they don't like to come to hospital frequently.
Thank you. Lastly, Alberto, what do you think?
Yes,
Would you vote for Inclisiran?
Yes, Inclisiran is just arrived in my country. I think it's an excellent drug and not only very effective, just I hope it would be affordable. That's the problem that we have had with the PCSK9 monoclonal antibody. I definitely will vote in favor of include this drug in our vademecum.
Thank you, Alberto. Thank you, everyone. Maybe I'll just sum up the whole conversation this evening with 3 key points. I think we've heard this evening that Inclisiran has a very unique mechanism of action. It is so safe that we literally don't see very many of the adverse drug reactions that we've seen with some of the monoclonal antibodies, as pointed out by Chris earlier. And so Inclisiran has been quite well tolerated. However, because it's in terms of cost, it's going to cost quite a lot. However, what I've heard is also in our local setting, in certain settings, it might be a bit more affordable than the PCSK9 inhibitors. So Singaporeans, listen hard. If I were to vote for it, I think I would probably also have it in a formulary. The other point that we've heard this evening is because of the long interval of injections, it would be helpful for people who are non-compliant and you don't really have to have them come back so often. As opposed to PCSK9 inhibitors, it requires self-injections. That would not be so good for patients who are afraid of needles on their own. Whereas for the Inclisiran, you can get the patients to come back every 6 months to get an injection given by a nurse. And therefore, that would increase the compliance to use of Inclisiran. So I think there were a couple of questions about cost effectiveness. Inclisiran is still lacking cardiovascular outcomes with respect to longer term studies, but we know that it's in the pipeline and we all are hoping with a lot of bated breath to see how well it does. And of course, with a lot of the theories that go before, we know that lowering the LDL would always be corresponding with better CV outcomes as well. And therefore, we know that eventually, once that is shown, that we could show cost effectiveness with respect to the use of Inclisiran too. All right. I think that's all the time we have for this evening. I think this was a very rich discussion. Thank you, experts from all over the world. We have Chris from Poland, we have Alberto, we have got Bernard, and then we've also got Kritin. So this was a wonderful around the world discussion this evening. So I'd like to remind everyone that the proceedings this evening will be very shortly available on demand on the Radcliffe Cardiology website at www.radcliffecardiology.com. So please go there to watch again. And for those of you who are very supportive of the ISCP work, you can go onto the ISCP website and sign up to be a member because we have a lot of these nice short webinars that are useful for you at your demand. Before we go, I'd like to thank our faculty once again. And if you'd like to get your points for CME credits, please don't forget to submit your details at the bottom of the webpage to claim your certificates. With that, we will close the session for this evening. We thank you for your very active participation and the nice questions that you've posed to us. With that, a very good evening from Singapore, a good morning to the USA friends, and a good afternoon to our European friends. Farewell. We'll see you again in August for our next edition of A to Z. Bye-bye.
Bye.
Bye. Thank you.